I just want to start with two very quick remarks. Number one, this is a lecture that in the past was given by Ted Steinman, and this is the first time that I'm giving this right now, and the shoes to fill are pretty big. And Ted has been my teacher and my mentor for many years, and I'm very honored to be here right now. My second remark is, it wasn't that long ago that I was sitting for my renal boards, and I thought that I'm totally on top with polycystic kidney disease, and that was my strong topic. But I was a little bit disappointed because there are actually not that many questions on polycystic kidney disease, and I had the feeling that they are not that pertinent, and there are a couple of fields that I think the committees really like to test, which are maybe not the most impact topics about the pathogenesis and the clinics and the treatment of polycystic kidney disease that is important for you as a clinician or for your patients. So we have 45 minutes, and I'm starting now. I don't have any major disclosures except that I will talk a little bit about novel therapies and therapeutic ideas, and I've been co-investigator on a novel therapy that I will mention at the end, but there is no real commercial interest with that. So epidemiology is our topic number one, and ADPKD is quite remarkable because it is one of the most frequent monogenic disorders in humans. Probably 1 in 400 to 1,000 live births is affected. And if you think back about how many people you know in your lifetime between high school and college and families and extended families, there are probably a good number of people who actually have ADPKD. So it's common and we should know about it. The characteristic hallmark is that cystogenesis happens very early, probably at an embryonic stage, and cysts continue growing throughout an individual's lifetime. And the disease is characterized by expansion of renal cyst. Functional renal parenchyma gets compromised mechanically, later by fibrosis and by tissue remodeling changes, and progressive renal function loss and end-stage renal disease are inevitable. Typically, advanced chronic kidney disease and end-stage renal disease appear later in the 6th decade of life, depending on the mutation that an individual is carrying, and I will talk a little bit about that later. In the US, probably 4 to 10% of the end-stage renal disease and renal transplant population go to autosomal dominant polycystic kidney disease. It depends also a little bit about what referral center or what study you're looking at. And that gives us about 7 to 17 million people worldwide, okay? The burden of illness in ADPKD is, number one, through the cyst growth, the cyst expansion, and the progression to end-stage renal disease. But for a long stretch, for many decades, it is often indolent, and you can follow people's lab tests, and the creatinine slope is not is particularly shallow in the first couple of decades before it accelerates. The lifetime risk for hypertension is high. 80% of people with ADPKD have hypertension. 60% of people with ADPKD have significant debilitating problems with pain, either acute from cyst rupture events or from cystic kidney disease-related stone disease, or from other complications like cyst infections, or they have pain complications that are chronic through the mechanical effect of the enlarged kidneys. And there's a high number of extrarenal manifestations in this syndromic disease. Extrarenal manifestations are common, and they are often tested in exams, in internal medicine boards or nephrology boards. So we should discuss some of them. Number one, intracranial aneurysm. So there are many studies and many numbers, and they often differ very wide by their findings. But I think if we try to get the most reliable numbers between everything that is published so far, it looks as follows. We don't know much about the natural history. The prevalence of asymptomatic intracranial aneurysms is actually 2 to 3% in the general population. I didn't know that, but that's already a good number. Now, in people with ADPKD, this number is significantly higher. It's in the range of 10%. If you have to remember a number, it's 10 in ADPKD and maybe 2.5 in the general population. Now, this pertains to ADPKD all-comers. Now, if you have somebody with a family history of ADPKD and a known intracranial aneurysm, then the prevalence is in the range of 25%. If you have people who do not have a family history of intracranial aneurysms and ADPKD, but they still have ADPKD, the prevalence is probably in the range of 6%. Okay? So just to put these numbers out, there are no clear risk factors for ICA rupture in ADPKD, except if you have a family history. Everything else is a little bit common sense. Obviously, if you have somebody who has ADPKD and an ICA and has a hypertensive emergency, or who has cocaine abuse or so, then obviously these are single identifiable risk factors. But the strongest one epidemiologically is the family history. Typically, ICAs rupture earlier than in the general population, in around the age of 40. And the big questions that we're often confronted with is, are we screening people generally for intracranial aneurysms, or if not, who are we screening and what are our recommendations? So number one, people with a positive family history of ADPKD and intracranial aneurysm should be screened. I think this is a recommendation that everybody can remember. The other thing is, even if you have no positive family history of an ICA rupture, but you have ADPKD, then it is worthwhile screening for an ICA if you are in a high-risk profession. Okay, airline captains, crane operators. Okay, and then there are many relative indications. So the family history is uncertain. You have ADPKD, but you have been adopted, or you have a de novo mutation, or you are going into a major elective surgery, or you're going for renal transplantation. These are relative indications, and something that may happen in a board exam is that they don't make it super obvious. So, for example, it's not an airline captain, but a bus driver. But then there are other confounding factors. For example, particularly difficult to control hypertension or hospital admissions for hypertensive urgencies or so. These are relative indications that you should consider. Other extrarenal manifestations are polycystic liver disease. So liver cysts are found in a quite high proportion of ADPKD patients, up to 80%. It's mostly not symptomatic, but 20% who have polycystic liver disease in combination with their ADPKD have symptoms, and these are mostly women. And typically, the liver involvement does not cause progressive or end-stage liver disease, but it causes symptoms through its mass effect, compression of other organs, or abdominal pain, distension, early satiety, and so forth and so on. Obviously, liver cysts have their own kinetics of growth. They have their own propensity of getting infected, or to rupture, or to hemorrhage. So this is a disease that can be regarded in isolation in people with ADPKD. It is more severe in women, probably because estrogens as well as progesterone have a trophic effect on the cyst epithelia. And particularly women with multiple pregnancies who have ADPKD and who have liver cysts often see a more rapid progression or a more symptomatic course of disease. And then if you go into the KDIGO conference report on ADPKD from 2015, there are many other extrarenal manifestations of ADPKD. Some of them are more, others are less well known. Mitral valve prolapse is something that you may see every once in a while because it's not uncommon. But then there are other issues down the list that are less common. That pancreatic cyst, diverticular disease, abdominal hernias. I think if you look into the KDIGO report, there are many other things. I don't think the relevance for board purposes is very high here. You should at least just know about them. If you look at the renal function in percent, or you can put eGFR there, or you can put creatinine, serum creatinine down there. It remains very stable for actually most of an ADPKD patient's lifetime until the cystic burden simply by space occupation and compression of the functional parenchyma becomes so severe that there is going to be a inflection point at some point at which people start dealing with more advanced chronic kidney disease the way we know it, and then these people have anemia, these people have secondary hyperparathyroidism, and so forth and so on. But for most of the progression, you may often see relatively stable serum creatinine and not much altered renal function parameters. And if people don't know they have polycystic kidney disease, they would probably not know. They may have cyst ruptures or cyst infections that have more like the characteristic of an accident rather than a foreseeable complication that would come inevitably. Any questions at this point? Yes, please.
For the relatives of a patient with that condition, at what age do you start doing the screening? Is it 30 years old, like children? When did you start screening family for PKD?
It's a little bit, So, okay, that's a good question, because you see that the nature of PKD progression is actually indolent for most of the first couple of decades, unless you suffer from any symptoms. And so if you have somebody who is 20 years old or 30 years old who comes to your clinic and who really wants to know, then you can absolutely screen people. I think if you have a strong family history, you would offer screening, but there are many people who maybe don't want to know, or who may want to live their life, and if they make important decisions, about getting married or getting a job or so, then they would come. So there are no general recommendations for screening, even in people with positive family histories, but this is a dominant gene also, right? So in a family in which that disease is running, then you have usually members from different generations who are affected. They know about their high risk of being involved, and it's usually the patient who comes to you. Okay. We'll talk a little bit about genetics and pathophysiology, because this is important. And we'll talk particularly about the PKD 1 and 2 genes, structure-function relationships, then the intracellular signal transduction pathways and their relevance for therapeutic concepts, and then of disease pathogenesis and its mechanisms. There are only 2 genes that are well, I want to say well established in ADPKD, because there is always new research and there are new genes and proteins being discovered. But for the last 2 decades, PKD1 and PKD2 were the known genes, and these proteins here are the gene products. They are quite unique. PKD1 is a gigantically large gene, 46 exons. It spans over 50 kilobases in your genome, and it gives rise to a 4,000 amino acid protein of 460 kilodaltons. It is particularly complicated to do genetic screening and research for PKD1 because there are actually 6 pseudogenes that are up to 99% identical, but they do not give rise to a functional protein. But if you want to develop primers or sequencing strategies or so, then you will have a high chance of screening through many pseudogenes that don't have any pathophysiologic relevance. And then there are a family of PKD1-like genes, named PKD1-like 1, PKD1-like 2 and 3. So that makes genetic screening difficult, especially at the discovery age. Right now, obviously, we know all these things, and there are more automated platforms and procedures. PKD1 mutations account for 85% of ADPKD cases, and PKD1 mutations also give rise, in general terms, to the faster progressive form of PKD. The average age of end-stage renal disease in carriers of a PKD1 mutation is around 55 years. This is different from the PKD2 gene. What do I have here? Okay, so this is the PKD1 gene product with its conserved domains and the other PKD1-like genes next to it. I don't think I want to go through this in much bigger detail. PKD2 is a smaller protein, but it's still sizable, 1,000 amino acids, and it gives rise to about 15% of ADPKD cases. Okay, so these are numbers worthwhile remembering. 85% PKD1 mutation, 15% PKD2 mutation. PKD2, slower progression. Average age of end-stage renal disease in PKD2 mutation carriers, 75 years. Okay. PKD2 evoked a little bit more interest for electrophysiologists and structural biochemists because it really looks like a cation channel of the TRP family. So the research is pretty exciting in that field because people make hypotheses based on putative calcium channel activity of the PKD2 gene product as a determinant in its pathogenicity. However, this got pretty severely challenged over the past couple of years by a number of studies. If you know a little bit more about this and you have this model in your head that there is a calcium channel that is constituted by the PKD2 gene product and that a calcium current in the cell is the determinant of cystogenesis, this is probably no longer sustainable in this simplicity. Okay. But we don't have an alternative, and we don't have a good alternative model for this right now. We know that PKD1 and PKD2 gene products interact, they form a functional complex, and they go to a particular site in the cell, particularly in the renal tubular epithelial cell, and this is the primary cilium. And actually, all cells have primary cilia, very few exceptions, and cilia are a very specialized organelle. They often have a signal receiver type of functions and are packed with protein modules that can translate extracellular cues, flow, mechanosensory signals, chemical signals, and PKD1 and PKD2 gene products are probably located a little bit in this hypothetic field that some signal transduction event really occurs through this, which is perturbed by dominant mutations. And things get more complicated by the fact that there is a very small proportion of ADPKD people who did not have a PKD1 nor a PKD2 mutation, but who have a strong family history. It's probably 1% or less, but discovery is going on. And a third gene called GANAP, which is a glucosidase in the endoplasmic reticulum, which has been shown to be responsible for the maturation of PKD1 and PKD2 as they are being synthesized and transported to the cilium, that this gives rise to ADPKD, also with a strong liver cyst phenotype. And so if you want to remember just one aspect of this, other than the 85 to 15% dichotomy in the PKD1 and PKD2 gene mutations, is number one, 55 years end-stage renal disease on average in the PKD1 mutation carriers, 75 years of age for end-stage renal disease in the PKD2 mutation carriers, and PKD1 and PKD2 probably exert some cellular function in renal tubular epithelial cells at the primary cilium, whether that cilium and this protein complex acts as a flow sensor or some other type of signal transducer is still not sufficiently answered. At a different stage in this talk, I will show you a data set from a CRISP study, which was a radiological consortium looking at total kidney volumes and total cyst volumes of people with PKD1 and PKD2 mutations. And but what I want to show you here is on this, well, it's a landmark study. If you follow ADPKD patients by MRI over many years, each individual patient has a particular characteristic kinetics of total kidney volume expansion. And this entire cohort looks like all these trajectories go up exponentially. And if you stratify them in the two cohorts of who has a known PKD1 mutation and who has a known PKD2 mutation, you see the red cohort moving steeper and faster and earlier in life, and the blue cohort with the PKD2 mutation more shallow and at a later onset. What other questions do you have? Okay, so I'll just I'm going to skip through this very fast because this is not a slide where I want to show you the signaling pathways in PKD, because if I'm a cynic, I could say like whatever pathway has been tested for its role or for its contribution in ADPKD, something has been found and something has been made attributable as a mosaic stone in that whole PKD pathogenesis. But if we go back to the basics, the primary cilium plays a role, the PKD1, PKD2 protein complex plays a role, whether or not through a calcium signal. But the other interesting finding is that in cystic kidney epithelia, they are characterized by a high intracellular concentration of cyclic AMP. And cyclic AMP can be generated by multiple different signaling inputs. An important input in cAMP generation is through the V2R, through the vasopressin receptor, which signals through a stimulatory G protein and produces cAMP. Another pathway is through repression of an inhibitory G protein through somatostatin, which would otherwise lead to cAMP formation. And this is the cAMP contribution to PKD pathogenesis that has been exploited in a couple of therapeutic approaches, namely with somatostatin and with Tolvaptan, and I will get to this in a little bit. Whatever happens inside the cell, and you just remember that labyrinth and that maze of different signaling pathways that may all contribute a little bit, normal tubular epithelial cells should expand along a longitudinal axis in the developing nephron during embryogenesis and early kidney development. However, if these growth and these geographical cues for the individual renal tubular epithelial cells are perturbed by a mutation or by some aberrant signaling, the cells are losing their compass and they are not necessarily dividing around a proper longitudinal axis, but maybe randomly in all direction, and that is probably the first initiating developmental step for cystogenesis and for expansion of a tubule, and maybe everything else that comes later with CAMP signaling, with the contribution of CFTR, vasopressin, and is not cystogenesis, but just cyst expansion that occurs over somebody's lifetime. Just a thought. In the end, you arrive here. This is an explant of somebody with a kidney that was 45 centimeters long. And I'll go to the next chapter, which is about diagnosis and prognosis, and I'll just give you the opportunity to ask questions if you have any. All good? Okay, so we'll review some diagnostic criteria for PKD. We'll talk about total kidney volume as a biomarker for PKD progression. I'll show you some data from that CRISP study that I mentioned already. And we'll be able to name some common differential diagnosis for autosomal dominant PKD at the end of this section. So, imaging is the cornerstone of PKD diagnosis. Typically this happens in an office setting in somebody who wants to know if they have PKD, probably because of a family history. Ultrasound scanners easily detect cysts of 1 centimeter in diameter. If you push the limits and go to investigational ultrasound scanners, you can even go down to 2 or 3 millimeter, and I think as technology develops, this 1 centimeter from a couple of years ago is being challenged more and more. MRI is better. Resolution limit is commonly around 2 millimeters, but I don't think that MRI is recommended as a first-line diagnostic means for ADPKD. In this study by Jared Grantham, it was shown that the actually detected renal cysts that we are able to pick up just constitute the tip of the iceberg, and this connects it back to what I told you about genetics and pathogenesis of cyst expansion, that cystogenesis is one process, cyst expansion is the other process. So maybe PKD1, PKD2 signaling plays a role at some early stage in embryonic kidney development. Once the initiating event is gone, then we're only talking about long-term expansion, and there are many cysts under the resolution threshold of whatever, ultrasound or MRI, and if you go down to histologic sections, then it is clear that we really just see the tip of the iceberg. The diagnostic criteria that we use for ultrasound diagnosis, I'll just skip through this. This is the detailed KDIGO report on the Ravine criteria. Yeah, but the modified Ravine criteria for the ultrasound-based diagnosis of ADPKD are stratified by age and by the amount of cysts that you can detect. Okay, and it's commonly accepted based on this paper, and this is a modified paper to the initially published Ravine criteria from 2009. The presence of more than 3 renal cysts in an age group of 15 to 39 years has a 100% positive predictive value for the diagnosis of ADPKD, okay, regardless of the family history. If you go up by the age, then you imagine that the natural progression of cysts or the ongoing cystogenesis above the detection threshold has progressed. So if you go to people of the age of 40 to 59 years and you see more than 2 cysts on each kidney, you have a 100% positive predictive value. Okay? So more than 2 cysts on each kidney, right? In the earlier age cohort was 3 renal cysts, regardless if they're all in one or if they are distributed over both kidneys. If you are more than 60 years, then you need to have more than 4 cysts on each kidney to be diagnosed. Okay? Usually at that age, the disease is so progressed, regardless whether you're the carrier of a PKD1 or of a PKD2 mutation, that the cystic burden is much higher. So this is why the threshold is higher. Okay. Now, for disease exclusion, and this is important in a dominant trait, if you have people between 30 and 40 and you have no renal cyst detected whatsoever by ultrasound, then the negative predictive value for ADPKD is in the range of 99%. Pretty good. Okay. Normal kidneys or 1 renal cyst and not more than 1 renal cyst at an age of 40 and more also exclude ADPKD. This is a table that is probably memorizable, but I don't think they will test that. So renal cysts are the first verifiable primary manifestation of ADPKD, and before you get flank pain, hypertension, gross hematuria, reduction in your GFR, kidney infections or cyst infections, you need to have the presence of cyst. The inverse correlation between the kidney volume and the kidney function has been observed for more than 30 years, and that gave rise to evaluate the kidney volume as an independent biomarker for ADPKD progression, simply because GFR and clinical symptoms, creatinine, are unreliable. You remember that slide that I showed you with a relatively shallow decrement in eGFR over many, many decades. That gave rise to the CRISP study, and in the CRISP study, for the first time, the total volume of all renal cysts combined has been evaluated, as well as the total volume of kidney parenchyma in total, along with the cysts. And dependent on the age and the gender, the entire cohorts progress in this fashion. This is blue women and red man. The same trajectories are found for total kidney volume and for total cyst volume. The mathematical algorithms for the total cyst volume estimation are a little bit more complicated than just estimating the size of the total kidney volume. So the kidney volume has been basically established with this landmark study in the New England Journal as an independent biomarker of ADPKD progression. And it shows you one important thing, that this inflection point that we have here looks particularly sharp if you look at kidney function by eGFR or by creatinine. But the progression of total kidney volume increment is basically an exponential trajectory throughout somebody's life, and the slope really goes up, or let's say the slope for the glomerular filtration rate has been found to really go down at volumes at cutoff. It's difficult to speak about a cutoff, but when kidneys are hitting a total kidney volume of about 1,500 milliliters. Okay. So you can draw an imaginary line here, probably between 1,000 and 1,500 milliliters. That is a magic line where, regardless of your age, the trajectories start becoming very steep and pointing up. Okay? Now, total kidney volume assessment is probably just going to remain a research biomarker. You will not send every one of your ADPKD patients for annual assessments of your total kidney volume. You can make estimates. There are some mathematical models how you can use ultrasound criteria to estimate your total kidney volume. But it is important if you have patients who may be interested in the participation in ADPKD therapy studies, because whoever tries to market a new drug and look at the potency of a new medication for the modification of these trajectories will probably much likely look at total kidney volumes than at GFR or at other clinical criteria, or at somebody's creatinine trajectory, which is totally unreliable. Okay, so your patient who has a total kidney volume of, let's say, 1,000 to 1,500 is probably an ideal study participant. And I jumped over this, but ADPKD is not the only disease that gives you renal cyst, and it's also not the only cystic renal disease that is autosomal dominant. The spectrum of cystic diseases of the kidneys is very wide. You probably heard a little bit about that by Friedhelm Hildebrand. I only want to mention the autosomal recessive polycystic kidney disease just for completeness sakes, because it's the recessive counterpart. You may want to think of the autosomal dominant, right? But it's a pediatric disease, and it's a very devastating syndrome with a high amount of lethality and renal impairment very, very early in embryonic and postnatal development. But you may see these people with the renal cysts and diabetes syndrome, RCDA. This is HNF1 beta disease. It follows an autosomal dominant trait. These are people who have something within the spectrum of KCUT, congenital abnormalities of kidney and urinary tract. Many of them can have cysts that fulfill Ravine criteria. Others can have just a unilateral kidney agenesis, or a horseshoe kidney, or duplication of the ureter, and other congenital malformations. And it has a strong association with the MODY5, the maturity onset diabetes of the young. So if you have multiple people with some type of genetic kidney trait, and there are family members who have cystic kidneys, and you know from somebody else who is on dialysis, or somebody else was diagnosed with a solitary kidney, and there are other people who have diabetes. This is not that uncommon. It is also important that if you know about this familial trait of HNF1 beta mutation, these patients have a higher chance of developing renal cell cancer. And if they have only a solitary kidney, this is a big problem. Other cystic kidney diseases are clearly syndromatic and part of other multi-organ malformation syndromes. Tuberous sclerosis, I will not talk about in detail. Von Hippel-Lindau disease is a cancer syndrome with cerebellar hemangioblastomas, and other differential diagnoses that are listed in this table and that you can look up in the KDIGO report. Genetic testing in ADPKD is straightforward, because we look only at two genes, PKD1, PKD2, right? And there are primer sets, and there are chips, and there are standardized automated ways to go through this relatively fast. Not a lot of research discovery in this, because those two genes are very well characterized. But should we test everybody genetically And the easy answer is no, but then the more complicated answer is who are we testing and why are we testing and what particular use would we have from a genetic test. So number one, if you really need a firm diagnosis, but imaging results are equivocal, the family history may be unreliable, and you just need to know because you want to become an airline captain then genetic testing is useful. There are people who have ADPKD, but they don't have a family history. And their proportion is actually not that small. Depending on what study you're looking at, the highest number that I've seen is in the range of 20%. Okay? I think the true number, well, maybe this is true, I don't know. I think it's probably lower, but reports suggest that up to 20% may have no family history. So what is the underlying mechanism for ADPKD? Possibility number one, de novo mutation. You have two alleles. It's a dominant disease. You only need one missense mutation in one allele, and you may have fully penetrant ADPKD. It's worthwhile knowing if this is new. The more problematic things are, well, it's probably not that problematic if you're adopted and you know about this, and you have polycystic kidney disease. Maybe then you want diagnostic confirmation. But there are people who don't know they're adopted, or there are people who think that their father is their father, and the rest of the family thinks the same, but maybe it's not. Sometimes you run into these questions where you think, should we really pursue this very aggressively, right? And the same thing happens when you screen people for transplantation, and all of a sudden, when you're looking for a living-related donor, and there is no real good haplotype, match or so within the family, and you're asking the appropriate questions then. So always think about the two sides of the coin when you do genetic testing. There are truths that are bigger. You want to clarify the diagnosis in unusual disease presentations or with negative family history. I mentioned that. And then, oftentimes when you enroll into a study, novel therapeutic, it is part of the study that you verify that this is indeed a patient with an ADPKD mutation for research purposes. Any questions? Okay. I have to blast through the treatment slides. The good news is, not good news. There is no causative treatment for ADPKD, right? So we can make it very short. There is a lot of research in treatments, and we should go a little bit through past and present trials. And I don't think it will have entered the board slide, the board question set about halt PKD studies, but this is maybe something you should know. Published in the New England Journal, two back-to-back studies on one working hypothesis: RAS activation, renin-angiotensin-aldosterone system, is high in polycystic kidney disease, probably because of the effects on the soft tissue when cysts expand and intrarenal hemodynamics get disturbed. So, question: if we block the RAS system with a single agent, or even very aggressively with dual therapy, what effects is that going to have on the progression of polycystic kidney disease? And then these are blood pressure agents. Obviously, when we use them either alone or in combination, will a subtle versus very aggressive blood pressure management positively or negatively affect the rate of progression of cystic kidney disease? And does it have an effect when you start early versus late treatment? So I have to go through this very fast, but basically these were two studies. One study, early ADPKD, GFR in the HALT A study was more than 60 milliliters per minute. So all the people had PKD all the people had hypertension, but renal function was preserved. 558 patients underwent randomization into a standard blood pressure group, so target blood pressure 120 over 70 or to 130 over 90 systolic, or to a low blood pressure group, so with systolics of 95 to 110. And within these two groups, they were further randomized to a combination of lisinopril and telmisartan or lisinopril and placebo. And the outcomes for the hard endpoints are there is indeed a change in the progression of total kidney volume over time in the people with the low blood pressure targets. And this is probably the most interesting positive outcome here, but it does not matter at all if you achieve this by lisinopril alone or by the combination of lisinopril and telmisartan. If you look at the eGFR over time, these curves do not separate to the very end. And you can say, well, these are people with very, very early ADPKD, and their renal function is preserved, their GFR is more than 60, even over 8 years. You're still somewhere in the shallow part of that renal function decline curve, so you may not see an effect in eGFR yet, but you may already see a good effect in the total kidney volume over time when you have your blood pressure goals very aggressively and very low. Therapies were well tolerated. Low blood pressure targets were better basically in all subgroups analyzed. And I had this already, and no difference how you achieve this, either through combination therapy or through single therapy. The HALT-B study looked at advanced ADPKD. Inclusion criteria included eGFR ranging from 25 to 60 milliliters per minute. So basically CKD stage 3 people, and here total kidney volume was not an outcome measure. Here people, the outcome was basically 50% reduction in your GFR over the study period until you would reach a hard endpoint, or death or end-stage renal disease. Also, large cohort, 486 people together in HALT-A and HALT-B. There were 1,000 people screened and followed over 8 years. So that's a very, very large study. But the final outcome is that there is no advantage over lisinopril telmisartan over lisinopril placebo if you look at these hard endpoints. So basically, in summary, in early ADPKD, combination of lisinopril and telmisartan did not significantly alter the rate of increase in total kidney volume. Sorry, did I write did not? Okay. Go to your syllabus and say did absolutely alter the rate of increase in total kidney volume, but not GFR. Okay, not GFR. The total kidney volume was positively affected by the low blood pressure goal. Okay. Now, as compared with standard blood pressure control, rigorous blood pressure control was associated with a slower increase in TKV. This is the main outcome, okay? No overall change in GFR. Other outcomes were the decline in LV mass index, urinary albumin excretion. No significant differences were found there. And then next, monotherapy with an ACE was associated with blood pressure control in most patients with ADPKD and stage 3 chronic kidney disease. That was the HALT-B study. Addition of an ARB did not give any further positive effects. Okay, a couple of negative studies. mTOR pathway inhibition was looked at in 2 large and 1 smaller study, one by Gerd Walz in the New England Journal of Medicine 2010, the other by Andreas Serra, back-to-back publications, different cohorts. One looked at everolimus, the other one looked at sirolimus. Both used total kidney volume as an outcome. No effect was seen. And then you should at least know about this hypothesis, namely that the reduction of intracellular cAMP is mostly amenable for a therapeutic approach through suppression of vasopressin. And there are many rat models who have polycystic kidney disease and who basically revert cyst expansion and who basically do not develop progressive cyst growth if treated with vasopressin receptor blocking agents, or very, very dramatically shown if they are crossed in an AVP negative background. So there is both genetic as well as therapeutic evidence from animal models that this works. And it has been evaluated in this trial, Tempo 3-4, Tolvaptan, a vasopressin receptor antagonist in patients with ADPKD, shows a clear change in total kidney volume over time that is beneficial for patients. However, the study had some problems, and number one, aquaresis is the most common side effect. Well, it's not a side effect, it's actually an effect of Tolvaptan, and that led to discontinuation in a very high amount of patients. And these patients, they basically, I mean, they have all their vasopressin receptors blocked, so they have very, very high urine output throughout the day, throughout the night, which is very inconvenient, and that led to discontinuation. And the other problem was the elevation in LFTs that posed a significant safety risk, and I'm talking about like triple digits increases in AST, ALT, and for this reason, Tolvaptan is not recommended for its poor tolerability in the treatment of a disease that goes a lifelong. Right? This is not a disease that you treat with all the inconveniences for a couple of months and then it goes away. This is something that you would need to tolerate very well, and that your liver needs to tolerate for many decades. Okay, novel therapeutic concepts go into proliferative pathways, EGFR inhibition, Src kinase inhibition. This is an investigational drug that has been studied right now in a phase 2 study. Results are still pending. The manufacturer, Cadman Pharmaceutical, hopes to bring this into phase 3 in this or maybe in the next calendar year. This is it.